All right, we are live. Hi, everyone. My name is Tim McMahon. I'm the Director of Marketing here at St. Joseph Hospital. And today I am joined by Dr. Sabine Manoli. Dr. Manoli is a surgeon here at the Breast Care Center, and she'll be talking to us today about some surgical options for breast cancer management. So, Dr. Manoli, I'll let you introduce yourself a little bit as well.
Hi there. I'm Dr. Manoli. I've been one of the surgeons here at St. Joe's for about 15 years. Originally grew up in Texas, but trained in Boston and have been in New England for 20 plus years. Spent a lot of my career taking care of both benign and malignant conditions of the breast. So hopefully for those of you joining us, we'll learn something today and maybe refresh some memories, good or bad.
All right, so the way we're going to work this today's Facebook Live is that I have a handful of questions that I'll be asking Dr. Manoli and that she'll be kind of responding to throughout the broadcast. But certainly, if any of our viewers watching have a question you'd like answered, post it in the comment section below. And if we have a chance to answer it on, live here on the broadcast, we'll put it right up on the screen so that we can get all of your questions answered as well. So we'll get things started off here. Dr. Manoli, one of the questions that I know you hear a lot is, what is the difference between a lumpectomy and a mastectomy?
So when we're dealing with breast cancer, the goal of surgery is to remove the cancer. And that can be accomplished in two ways. One, obviously, we can just remove the tumor from the breast and leave the majority of the breast behind. That would be referred to as a partial mastectomy or a lumpectomy. Obviously, the other option would be to remove the entire breast, and that's a mastectomy.
Okay, great. Thank you. All right. So another question we often hear is, how do you decide if someone is a candidate for a lumpectomy versus a mastectomy?
So, clearly it's dependent on several factors, one of which, probably the most important one, is the patient's preference. Some patients come and see me and they immediately know they don't want to save their breast. They want a full mastectomy. They don't want to take any sort of chance that anything is going to be left behind. And so they just opt for that from the get-go. Majority of patients, because we're doing really good job with screening mammography, they present when their cancer is quite small and early. And so the majority of their breast is healthy. And in those cases, we don't need to remove the entire breast. We simply need to remove the tumor. That's just a lumpectomy. Of course, if somebody has a small breast and a large tumor, that makes it a little bit more difficult to try to accomplish a lumpectomy. Lumpectomy, it's important to get clear margins around the tumor. So we want to just take the cancer in addition to some marginal tissue of normal breast that allows us to make sure we got it all. As you might hear a surgeon say, did you get it all? Yes, we got it all. So, lumpectomy, if the tumor is large and the breast is small, it becomes a bit of a challenge. And sometimes in those cases, we do have to go towards a mastectomy. Or in a patient that has what we call a multifocal tumor, where there's more than one tumor, several tumor sites within the breast, those are difficult to get around with a lumpectomy. And so those patients would need a mastectomy instead. The other thing is that we know in cancer outcomes, if we combine lumpectomy with radiation, we get the same outcome as a mastectomy. Some patients don't want to undergo radiation after surgery, and in those circumstances, it would be preferable for their cancer to go ahead with a mastectomy. So there's a lot of discussions that go into the preoperative planning for breast cancer patients, where we sort of decide based on the patient's preference, based on the size of the tumor, based on if there's multiple sites of tumor, what would be the best surgical approach for those patients.
Great, thank you. All right, another question we have here is, how do you decide if someone with breast cancer is going to have surgery first or chemotherapy first?
So this one, and a lot of times patients come in and they just want surgery right from the get-go. I think everybody's mindset is, get it out of me. And we sometimes have to really explain to them that if it's a more aggressive variety of cancer, like a triple negative breast cancer or a HER2 positive breast cancer, those are actually treated better with chemotherapy first. We have studies that show that long-term outcomes for patients with triple negative breast cancer or HER2 positive breast cancers are better if they get chemotherapy first, because the concern is those more aggressive varieties of cancer, the cancer cells might have already spread from the breast tumor into the body. And so by giving the patient chemotherapy first, we're actually eradicating that spread throughout their body before we're tackling the tumor itself with surgery. So those are folks where chemotherapy before surgery makes sense. We know from long-term outcomes it makes sense for them. The other time that we would approach a tumor with chemotherapy first is if somebody is very adamant to save their breast and to avoid a mastectomy. In those situations, the chemotherapy lets us shrink the tumor up front, which then might facilitate us being able to do a lumpectomy rather than having to do a mastectomy. So those two scenarios, the chemotherapy would come before surgery.
All right, thank you very much. All right, so another question we have is, why do you have to biopsy underarm lymph nodes when someone has breast cancer?
The reason is that is the first place that breast cancer tends to spread if it is on the move. So we're always looking to see how far the cancer has gone. Has it left the breast? Has it entered into the lymph nodes? That would be the first stepping stone of spread. And then if it has spread to the lymph nodes, how far has it gone beyond that? At that point, if we do find it in the lymph nodes, we would look through with scans the rest of the body to see if it's gone other places. So lymph nodes are an important sort of prognostic indicator of how advanced the cancer is, how far has it gone. It plays into the staging of breast cancer to know the status of the lymph nodes. So if the tumor is confined to the breast and is relatively small, that would be a stage 1. If it's a larger tumor but still in the breast, that would be a stage 2, or a smaller tumor with some lymph node spread would be a 2. Extensive lymph node spread, no matter the size of the breast tumor, would be a 3, and spread outside of the breast and axillary or underarm lymph nodes into other parts of the body would be a stage 4. And, one other comment in regards to lymph nodes with the COVID situation that we have going on right now and vaccines going out, please realize and remember that if you have a mammogram scheduled very shortly after you receive a vaccine, it is not infrequently that we have been seeing enlarged lymph nodes on the side that a patient receives their vaccine. So if at all possible, the recommendation is to wait 4 to 6 weeks after you get your vaccine shot before having a screening mammogram, because it might show enlarged lymph nodes and you might end up getting recalled for additional imaging because of the concern that the enlarged axillary or underarm lymph nodes are actually suggestive of cancer. More often than not, if it's right after your vaccine shot, it's probably from that. It's pretty rare that people would present with enlarged lymph nodes as the first sign of breast cancer. But unfortunately, right now with the vaccines going out, that's what we're seeing. And so a lot of people have been getting recalled on their mammograms for that reason. So if you can avoid getting a mammogram too soon after your shot, try to postpone it by 4 to 6 weeks.
Great, thank you. All right, another question. If I find out that I have a genetic mutation that increases my risk for breast cancer, do I have to have a double mastectomy?
Absolutely not. Basically, when you find out that you have a genetic mutation that increases your risk for breast cancer, you should meet with a breast specialist to have some conversations about risk mitigation or decreasing your risk. There are certain lifestyle choices you can make that will help decrease your risk. There are certain hormonal medications that can be taken that have an anti-hormone effect, or we call them hormone or endocrine medications. Sometimes those are administered to decrease your risk. But primarily what you need to do is decide if you want to keep your breasts. And if you do, we would put you on a very intensive surveillance schedule. So you would not only have surveillance with mammograms every year, but you would also have breast MRIs recommended to you once yearly. And ideally, we would try to stagger 6 months between a mammogram and an MRI. So for example, you'd have a mammogram every December and you'd have a breast MRI every June. In between those studies, we'd also have you have a physician breast exam twice a year. So again, with the same example of the December and June imaging studies, you would have a physician examine your breasts in March and September. And that basically allows us to keep either an imaging eye or a hand on your breasts every 3 months. That would not prevent you from developing breast cancer, but it would certainly allow us to monitor for it and find it very early on. Obviously, your biggest way to decrease your risk for breast cancer would be to have a double mastectomy. It reduces your risk not to 0, but as close as we can medically get it, down to 1 or 2% chance of developing breast cancer. And the reason for that is that even with a double mastectomy, there's always theoretically some breast cells that are still left in your body that could potentially become cancerous. So we can never get down to quite 0, but very, very close. And so, people say, well, if I don't have a double mastectomy, can I prevent myself from getting breast cancer? No, you cannot prevent yourself, but you could decrease your risk to as close to 0 as we're able to get it. If you choose the surveillance option where we're kind of doing the mammograms and physician exams and breast MRIs frequently, you wouldn't prevent yourself from getting cancer, but we would be able to find it very early on.
Great, thank you. And just as a brief pause between questions here, we do have a few comments in our comments section. I just want to show you on screen. No questions, but kind of a nice thing. Amy Kelly says, Dr. Manoli is the best. Tina says, thank you for doing this, Dr. Manoli. You're a rock star. And Pauline says, thank goodness they search mine. So thank you for the comments, folks.
Aw, thanks, guys.
Dr. Manoli, you're very popular. In fact, when we were just promoting this event, we got a lot of nice comments on Facebook specifically about you. So
thanks, guys. It's nice to have fans.
All right, so we got a couple more questions left here. So our next question here is, what are my reconstructive options after breast cancer surgery?
So this is, probably a better question for a plastic surgeon, but I obviously have quite a bit of familiarity with this topic because, we as breast see patients from right out of the gate. As soon as they get their biopsy, we're the ones to meet with them and kind of lay out the game plan for their treatment. And many times our initial conversation doesn't just include conversations about their breast surgery for their cancer, but also, are we going to do chemotherapy afterwards? What does that entail? What does radiation involve? And if we're planning for a mastectomy, patients often say, well, what are my reconstructive options? So I know a lot about it. I don't belabor it because I let the plastic surgeons handle that topic, but, certainly even after a partial mastectomy, there are reconstructive options available. And what those procedures entail is either rebuilding your breast tissue with your own tissue, which would mean transferring a portion of fatty tissue and skin from your abdomen or your back forward to your chest to rebuild a breast. Or you can have reconstruction with something that's not you, which would be like an implant-based reconstruction. And the timing of reconstruction is also variable. Some people, they opt to have their reconstruction done immediately at the time of mastectomy. That does give us a lot more options in terms of what skin we leave on the body, which allows reconstruction to take place. If we aren't planning for reconstruction immediately, we take a lot of the skin off the chest at the time of mastectomy. And that means even though we've done that, there's still options for reconstruction later. It's a longer rebuilding process later for the plastic surgeons and the patient. But obviously, if you're planning for a mastectomy and you are interested in reconstruction, we have you meet with plastic surgeons before we even do your mastectomy. We want them to know what your body looked like before we started and what your goals are when we're all done with everything. And one thing to note is reconstruction is generally done in stages. So There's a big part of it that can be done at the same time as your mastectomy, but it's never completely done at that point. There's always steps that need to be done to kind of tidy things up and make it look as you want it and to kind of get to the final product. So that's another thing I try to impart on the patients in the beginning is, don't expect to wake up after mastectomy and, have your reconstruction be what you want it to be. There's still going to be some tweaking. You're not going to wake up looking like you did when you went to sleep under anesthesia. You still need to go through a few more steps, but there's definitely lots of really good end results. You just have to be patient during the process. And the other thing I try to remind patients, because my job is to take care of their cancer, I try to remind them that even though, there's a lot of sort of cosmetic considerations tied around women's breasts and their femininity and those body parts, my goal is always, let's take care of your cancer first before we start worrying about how you look. It's important, and I'm not saying it isn't, but it certainly needs to take a second seat to the first priority, which is let's get rid of the cancer so that you can enjoy looking good afterwards.
Well, and to that point, Pauline commented that, reconstruction saved my life. So I think that definitely kind of emphasizes that whole point.
It's the life after, so you have the cancer part that you save them from, but then they've got their life afterwards that you want to make it as good as it can be for them after. So that's important. And that part is the life that they live every day and they remember every day, whereas the cancer part of their life hopefully becomes a distant memory.
Absolutely. All right, so we have two more questions here. First one is, how did I end up with cancer? Breast cancer.
I get this question almost every patient I meet, because all of a sudden they start to feel like they did something wrong or they failed to do something they were supposed to in their life. And it's none of those things. And, I just want people out there to know that you didn't do anything. It's not your fault. There's really nothing that you could have, not one single thing you could have done differently. It is just one of these unfortunate things. And it's generally caused by a number of different things, one of which could be genetic. So even if you don't have a genetic mutation, it can still run in families. It's just not a identified mutation that affects the entire population of the world. But it can run in families, so there can be a genetic reason. It can be environmental, things around us, around all of us. We have an extreme exposure to plastics in our world, and that can cause it. There are radiation rays all around us, our cell phones being one of probably the most common sources of radiation to our bodies. And sometimes it's honestly just bad luck. Cancer develops from one of your own body's cells. The cell kind of becomes a rogue cell, develops all sorts of abilities to multiply on its own and to spread out of the original organ system it started in. And that's what a cancer is. It's your own body cell, but it just became a crazy cell that started having a mind of its own, and your immune system didn't catch it and kill it. So you didn't do anything, and it's not that you have a weak immune system. It's just that these things happen. They happen to the best of us, and there's nothing that you can do once you have it other than, go through the treatments and take care of it and, do what we can do to not have it happen again. But yeah, it's not your fault, and you couldn't have changed anything and done it differently to try to avoid it.
All right, thank you. And our final question of this afternoon is, when should I start having mammograms?
So I think this one is important because there's so many different guidelines out there. But most importantly, if you are a woman of average risk, so that's somebody who does not have a family history or not an extensive family history, definitely not someone with a genetic mutation, you should start your own breast self-exams at the age of 18 to 20, and you should start having regular yearly mammograms at the age of 40. If you have a genetic mutation, that is, you have it in your family or you've identified it in yourself by blood testing, then you need to start having imaging at 25. If you haven't identified the genetic mutation until later, let's say 30s, then you need to start at that point having imaging done, and it would include mammograms and breast MRIs, physician exams and breast self-exams. And so basically, anybody with a family history, let's say they don't want to go for genetic testing, but they have an extensive family history, probably good to start imaging at least at 35.
All right, great, thank you. And just because we got a couple extra comments while you were chatting, let's see, Vivian says, thank you, Dr. Manoli, 15 years and going strong.
Awesome.
And Carrie says, very valuable information. Thank you for taking the time to do this video. And certainly if folks have questions after the fact, this video is automatically posted to Facebook so you can watch it later. But if you have specific questions, feel free to leave them in the comments section. And I'll relay those to Dr. Manoli, and we'll make sure to try to get those answered. Again, even later this afternoon or tomorrow or in the future. So I believe that is all we have for time and for questions today. But again, I just want to thank Dr. Manoli for coming on, for joining us as part of our Meet the Experts series, where each week we'll be interviewing an expert from St. Joseph Hospital, different departments, cancer center, breast care center. In fact, even like later this week, we are talking to some folks in our senior behavioral health unit. So keep up to date, check us out on Facebook, YouTube, LinkedIn, and we'll be sharing great information every week. And finally, again, thank you, Dr. Manoli, for joining us. I think that was great information, and we really appreciate your time.
Thanks, Tim. Thanks, everybody out there. Have a good afternoon. Bye-bye.
Thank you.